I'm just going to read a short bio on Amy, and then she's going to launch into her slides. I wanted to start by thanking Amy for coming. Amy and I have worked together for a number of years, and she is just doing an amazing job as the executive director of the National POLST project. Amy's in Oregon, where it's already late at night, but Amy sometimes gets me to meetings at 5 o'clock in the morning. So she said it was payback time. So I so appreciate that Amy is here. Amy is a lawyer, which we don't hold against her. She is passionate about patient autonomy, medical ethics, and of course, POLST, and teaches on those topics as an assistant professor at Oregon Health and Science University, OHSU. In 2013, which is when she started with National POLST, she was honored to present POLST to the U.S. Senate Committee on Aging. And prior to this job, Amy was an associate director of OHSU's Center for Ethics and Legal Counsel for OHSU. In 2011, Amy completed a 2-year fellowship in interprofessional healthcare ethics, a combined program between the OHSU Center for Ethics in Healthcare and Portland State University. She's a 2015 Practice Change Leader for Aging and Health, a year-long program jointly supported by the Atlantic Philanthropies and the John A. Hartford Foundation. And she's a Hartford Change Agent through the Hartford Change Agents Initiative. Amy loves good food and wine, so you'll fit in with us, traveling, and enjoys staying active by running, kayaking, paddle boarding, walking her dog Maggie, and hiking with her husband. Amy, thank you so much for coming. As you know, POLST is very important to us in Hawaii, and we are really glad that we are not only an approved program, but actively participating in National POLST. So we really look forward today to hearing what's new with POLST. So take it away.
Yeah, thank you so much for asking me to be here. So today I'm talking a little bit about the past, but mostly about the present and where we're going to be going. So feel free to interrupt with questions. You can put them in the chat. I'll pay attention. Or as Jeanette said earlier, you can reach out to her or me after the presentation. So in almost all my presentations, I include this quote because I really think it captures the essence of what National POLST is. The organization exists to build consensus among state programs so that POLST can be successful nationwide. No state can be truly successful on their own because the patients are always going in and out. You don't have to worry about border states, but I get a lot of questions of people from the mainland going to Hawaii asking if their POLST is going to be valid. So we do need to work together to be successful, and I'm honored to help with that process. And thank you all for being part of it too. There's a lot that we can do, but it all distills down to keeping POLST easy. It needs to be simple and consistent. And this helps patients use it if they want, and healthcare professionals, including emergency professionals, know how to have the conversation, to translate patient preferences onto the form, and then to recognize and honor the form when it's presented. And we do this nationally by encouraging consistency among POLST programs. So I have a couple of quizzes. These are very low key technology-wise, so just type in the chat. What year did the organization that is now National POLST start? I'll give you a hint, POLST started in 1996, so it was after that. So the answer is, Jeanette got it, 2004. So to make sure, so to give a little taste of where we've been, POLST started in Oregon. It's the mid-90s. The idea started in 94. The first form was around 96. But in 2004, the task force was started. And this was actually a combination of Oregon's POLST program and national, and they were housed together. But the reason that National POLST was really created is because 6 states had started POLST along with Oregon, and they realized that they were already deviating in the name of the document, the color, and kind of what they were doing. And they wanted to build consistency because they did see that this could be a national thing. So they started the whole endorsement process, trying to encourage states to have that consistency with implementation and form elements. And we continue that work today. In 2009, Hawaii started their POLST program. And you beat me to the punch because I started in 2013 working with POLST. In 2017, I moved the National POLST headquarters from Oregon to Washington, D.C. We really wanted to show ourselves more as a national organization and have a presence in D.C. And then 2019 was a big year. We officially stopped using Paradigm, so we're just National POLST. We had our first plenary assembly meeting. I'll talk about what that is in a minute. and we introduced the National POLST Form. So where we are now, this is a snapshot of kind of what our organization is. You've got the plenary assembly, which is the state leaders. We invite 2 people from every state to participate. Jeanette participates from Hawaii. And this is the group that's really focused on how do we implement POLST? What are the policies that we should have? What is the guidance? What research should we be doing? That kind of thing. The Leadership Council is really like our board of directors, focused on the sustainability of the organization. The national office is 1.5 FTE. I'm full-time, Carissa is part-time. And then we have national advisors in 9 different areas. And we are looking to bring a pediatric advisor on board as well as a consumer advocate. We also have we updated our map earlier this year to show, it used to just show what program levels we're at, but we also really want people to consider adopting or adapting the national form. So we've combined both of them together. This shows obviously endorsed, I backed up, sorry. Endorsed, active, or unaffiliated. We're trying to keep this map simple, even though it's somewhat complex. And Hawaii, of course, is endorsed. So the darker pink states. If a state is active, meaning that they're on the plenary assembly and participating in our governance, we show them in light pink. And then we have a couple of states that are unaffiliated. This map also shows whether a state has adapted or adopted. Adapted meaning you've just taken the form and run with it. Adapted means that you had to make some change due to state law. And we try to keep that to a minimum. If you're familiar with our old maps, you'll know that we no longer have mature status on here. The plenary assembly voted to get rid of that 2 years ago now, and instead replace it with something we're calling endorsed with distinction. And that program will be rolled out this year. The reason we did this is mature status was really focused on level of penetration, how much POLST was being used and how widely it was used in the state. And that really doesn't make, and it really isn't the goal for any POLST program to show that. And instead, we wanted something to show that we value good leadership, sustainability, education, quality assurance. So endorsed with distinction will be these different areas, for example, patient education, where if a state does a really great job, they'll be able to get that distinction, and we'll put that on the website. And that will be something that we hold out to other programs asking, how do I do patient education? Look at Hawaii, they've done a great job. That's kind of the goal of it, as well as to help states that are still trying to get funding. It's helpful to see that endorsement is not the end, that in fact, there's more work that needs to be done. Endorsement is actually, it's an important bar, but we're just saying with endorsement that you have a form that meets our standards and that you're implementing the program correctly. It does not mean that you're statewide, but you should be working towards that. So almost every single state does have a program, and they are all using it at some level. Even the white states here actually all have POLST forms. I actually heard last week, we haven't updated this, that Alaska adopted the National POLST Form. So they're going to be running with that. South Dakota has a form, they just haven't used it yet. And Mississippi has a form, and thankfully they're not using it because it's bad, but it's generally available. We also are really encouraging pediatric populations. Again, POLST should be available to anyone who fits our definition, regardless of age. And we have a signature requirement. The reason that we have these visuals is really to help states that aren't going along with kind of what we've decided is appropriate, and the other states, again, building that consistency, is we kind of want to emphasize where people deviate. And this actually really makes a difference. Again, if you remember our old map, we used to have this gray shaded states where if you didn't conform, we put you as gray. And I think within 24 hours of our posting that, Massachusetts contacted me because they were upset that they were being shown as gray. And we've learned that these visuals, if a state looks bad, they want to fix it. So we will take whatever we can to move people in the right direction. So next quiz, how many acronyms are there for POLST programs today?
And if I could jump in there, that means in other states, they don't call it POLST like we do, but they've come up with their own. So it is very, I'm sure Amy would, if she could have a magic wand, she would change that. But there are some very creative things out that, oh, look, people think there's 2.
Thank you guys for answering. So I'll take 2 answers here. Either 15 acronyms, or if you're going to spell out the acronym, then there's 17, I believe. Yeah, 17 names if you spell it out. So we have a lot, which, yes, if I had a magic wand, it would all be the same. But for National POLST, we no longer spell it out as physician orders, blah, blah, blah. Instead, we just call it POLST, and we describe it as portable medical orders. I know that throws some people off that it's no longer an acronym, but we couldn't come to agreement because one, we couldn't agree what the P should be. We knew it shouldn't be physician because that's inaccurate. As you all know, this is a team process, and we don't want to offend nurses or physician assistants, and we really want to emphasize that it's a team. And then also life-sustaining treatment. People were feeling that that was not value neutral, and we want to be perceived as neutral. So we couldn't come to agreement for anything else, so we're on POLST and portable medical orders. And that brings me to some other language considerations. I don't think many people appreciate how much discussion some of our committees have over what language we actually use at the national level. And part of my job is once we've agreed on language, and that goes through a lot of discussion, that's something I try to keep consistent in all of our documents. So for example, you'll see healthcare professionals in almost everything that we do. The exception is that on the public and patient side and on the national form, we use the word provider. Partially for the national form because of space, but for the public and patient side of our website, it's because research has shown, hey, the public generally doesn't understand what healthcare professionals are, but they understand provider. And so we're trying to obviously get our message across to as many people as we can. We use the term patients instead of public or consumers. And this is one that comes up probably every 2 years for discussion. The reason we use patients is we want to emphasize that POLST is not for healthy individuals. It's for somebody who is seriously ill or frail. And using the term patient is one more way that we can help distinguish it from people that should be having a POLST. We use surrogate mainly because that is the most generic of terms from a legal perspective, but there are 7 different terms for what you would call a patient representative. The intended population, just a note that we never use only. It's only for people who are seriously ill or frail. Because we don't want to be, there are times where somebody might not fall within our intended population, but it's absolutely appropriate for them to use, and they have a conversation. It's really up to the healthcare professional to make a decision if POLST is appropriate. We're providing guidance on who we're intending it for, but the professional is the one that puts their name and their signature on it. We also want to point that POLST is not just for emergencies. This was a big debate in 2019, and Jeanette, it's coming up again this year in September. Having artificial nutrition on the form. All states except one agreed in 2019 that it was important. It was not an emergency thing that we need to know about artificial nutrition, but it's such an important conversation that we should have it on the form, because the form is not just for emergencies, it's helping patients as they transition across care settings. And so we feel it's important to be on the front of the form as part of the medical order. Of course, if you don't discuss, you don't have to fill it out. And on the national form, we actually have a box, did not discuss, and that's fine. But we feel like it's important. And the conversation isn't being had elsewhere. So another reason we want it on there. And then finally, we of course avoid cost-effective statements. We really want to emphasize that POLST is about patient autonomy, not about saving money. A note on branding. We have our National POLST brand. Please don't use that. That's just for things that the plenary assembly does or the national office. But we have created state logos. So Hawaii, we allow them to either use it in pink or black. Hawaii uses it in black because I believe you guys use green on your form, if that's right. But we encourage all states to use this. And I appreciate that Hawaii has taken on using the logo because we're trying to build the sense of community. So thank you. So participation in National POLST, I personally feel, is very important. And I know that Jeanette feels the same. The whole reason, again, that we switched to this plenary assembly concept was when National was first created, it was only if you were endorsed did you get to have a seat at the table. And there's so many states that are doing great work, but maybe their laws don't allow them to be endorsed, or there's some reason why they can't be. But they still have an interest in POLST, and they want to see where it's going. So we encourage all states to participate because we want people to feel ownership over what POLST is and be able to make decisions at what goes on nationally. Because again, for consistency, we want committees to create policies that everyone votes and says, yes, this is a good idea, like the intended population document. Good idea. We vote to approve, and the hope is that states take it and use that, and so that we have consistency in even how we describe the population or who can sign a POLST form, things like that. So thank you, Jeanette, for being on the plenary assembly and being on the committee and all the work that you do. You are awesome and a great leader, so thanks. Now into other things we're working on. Our most frequent Frequently shared policies from my perspective, the appropriate use policy, I'll talk about that in a second. We just updated, it used to be distinguishing POLST from death with dignity. Now we're calling it distinguishing POLST from medical aid in dying. That was a substantive overhaul. Overhaul. So take a look at it if you haven't seen it for a while. We have a National POLST overview, which is kind of a 2-page document that I use when I'm talking to like legislators and just want to remind them of what we talked about. So it's a great overview that you can use to talk to state legislators or adopt for your own. Of course, our intended population. COVID policies, that was big this year. Our incentive and quality assurance policy, I'll talk about in a second. And then we just came out with trauma guidance this year. It was just voted to approve in April, and we got that posted at the beginning of May. So POLST and incentives. This is a really big deal. Payments for encouraging discussions about the execution of POLST for those who are intended population have become more widespread, and these incentives are more acceptable. And National POLST, from the very beginning, has been pushing back on this because of the unintended consequences. We used to have a statement on appropriate use policy, but we decided that it was such a big deal that it needed to be a standalone thing that we could hand out. So the problem with incentives, again, the unintended consequences that harm POLST and even the perception of advanced care planning generally. We see a big problem that voluntariness goes away, because if you're creating incentive, then the patient might not feel like they can say no, and they should always be able to say no. Or that you have a problem with completing outside the intended population. If you're giving a physician an incentive for every single one that they complete, a financial incentive, they're not going to really care about the intended population. Or it reduces the focus or the emphasis on the decision making. It encourages POLST for the wrong reasons. So this policy doesn't say that it would prohibit incentive. Instead, we say if you're going to have incentives, that you need to think about how to avoid these unintended consequences. And the policy gives guidance on what appropriate documentation can be used to help avoid it. We're really pushing mainly nursing homes, but other facilities. And I gave you the short link, so if you want to look at the policy, you can just go to pols.org incentive policy PDF. So again, we took it out of the appropriate use policy. The appropriate use policy then under revision, and probably share the revised version with you this summer because we're voting in September. But this is sizing periodic reviews, and we have reformed the section that forms should be fully completed, not just section A. We don't want POLST to be used as a code status document. It's more, but we also are adding 2 key concepts. One, that POLST medical order that should follow during an emergency, that they're talking about patient wishes and you should be following them unless you have a reason not to. And then 2, access to blank POLST forms should be restricted. We shouldn't be just posting them online for people to print out, and we shouldn't just be giving them to patients in like admission packets. We want to restrict it. It's a medical order. You wouldn't give a patient a prescription pad of paper. Don't give them a POLST. All right, so keep POLST portable. This is a big part of the work that we're doing today, both from the national form perspective and the technology. So the form was released in 2019, and that was a huge step in increasing the portability. The national forum is really the basis of everything National POLST is doing. So we're working on education and some other things. It'll be focused on using National POLST as the example, but it's also about the technology piece. So I ended up getting a lot of stories during COVID. For some reason, March and April were very busy last year with these kinds of questions. And I just want to share one from Cornelia, who is 71 years old, who is going to be traveling from Atlanta, Georgia, to stay with her daughter in Maryland for an undetermined amount of time. Her Georgia primary care provider confirmed she was appropriate for POLST and wanted to fill out one for her because she was a smoker, and she really felt like, given all of her medical conditions, being on a ventilator would not be for her. And she believed if she became ill, her daughter would probably take her to George Washington Hospital in DC, but they were also traveling. So it's possible that she could have received care in Virginia or Pennsylvania, depending on where they were. She talked to her doctor and they agreed, POLST interventions, is my Georgia POLST form enough? Or do I need to get one from another state? And if so, what state, what should I do? So, what my Cornelia? Will her Georgia POLST be enough, or does she need more? And Erica, I see your question. I'll talk about that at the end. All right, not to belabor it. Yeah, every state needs more. It depends. Physicians across states. Yes, physicians can only sign the POLST form for their state, but the question is, would that form be honored in another state? So for this question, so in addition to her Georgia POLST, I said that 4 other forms was best. That means that she needs 5 total to really be as confident as possible that her wishes were going to be honored. Maryland said that they would honor her Georgia POLST. Maryland will honor any POLST form. If the question is, will they recognize it as POLST? But they will honor every single POLST form. The challenge, though, is that if she goes there, they'll honor it, but then they'll make her complete a Maryland version of her on discharge. And the Maryland form is so different that that won't be honored in pretty much any state. So that creates even more of a challenge. And then Virginia, DC, and Pennsylvania all said that they were likely to honor it, but recommended that she get the state version, their state version of it, to be absolutely sure. And that was partly to make sure that EMS recognized it as a POLST form and that they felt comfortable honoring it. They didn't know that happened with the Georgia form. So this is, for me, this is terrible. I hate giving this answer because essentially it meant that I needed to go up and see 4 different doctors, get 4 different versions of the form. And that's just not something that we should be asking patients to do. With the national form, again, for providers, patients, and caregivers, if you have one version, everyone knows what it looks like. Everyone knows what it says, how to follow it, etc. It's easy for patients just to have one. No one has to worry about having more than one on them. Education, right now, we just talked about the fact that we have 15 different acronyms. To have to start and say, you might know it as MOLST or MOST or TPOP, but I'm talking about POLST and it's the same thing. That's really complicated for some people to get. Once we are starting, and actually the research committee is really excited because we're starting to get to the point where we've got 6 states now that have adopted or adapted the national form, we can start doing research, comparing what's going on in those states in a way that we haven't been able to do before because there hasn't been enough similarity. And that, of course, can lead to improvements with POLST. How do we make the form better? How do we make the process better? It's easier to support national policy. Right now, it's kind of complex because people see it so much at the state level that there's not a lot that we can do nationally. Not that we want the Congress to get involved, but sometimes it can be helpful. It can eliminate duplication of expenses. So I'm working on getting translations of the form instead of every single state having to pay for it. We can just do it together. And then, I can go on and on about why having one form is kind of easier than having 50 different versions of the same document. But it's not just on paper. So one of the other projects we've been working on is technology. It's about, for Cordelia, she has a paper version of it, but when she's going from Georgia, is there a way that we can transfer this electronically so that the Georgia medical record or registry, if they have it, would be able to talk to whatever Maryland or whatever registries, EHRs, or health information exchanges existed in those 4 states. And the systems really need to be able to talk the same language about POLST form data. So technology is really transforming care delivery. You all know that. What we are looking for is how do we make it easier for POLST? We have our technology guide that really focuses on these different things, providing advice and best practices. And then to promote the guide, we do have a 5-part webinar series, 3 of which we've already done, and they're available online for credit. If you wanted to get credit, you can look at our website, polst.org/tech-guide. We have 2 more, 2 are done. We've got 3 more left: interoperability, registries, and EHRs. The other technology work that I'm really excited about is actually what we're really talking about with data language. So CDAs are clinical document architecture, and it's basically the language that it's systems talking English to English rather than English to French. So the systems are talking the same language. You can have a POLST form in Georgia that talks the same language, a POLST form in an EHR in Georgia that talks the same language as the EHR in Maryland. If they can transfer the data, then they don't need to have anything else. We don't need a national registry to facilitate that exchange because they're talking the same language and can transfer the data. So the Office for the National Coordinator is a federal organization, and they are supporting the work of creating a POLST CDA, which National POLST is part of. So we'll be, again, using the national form as the basis of it, but making sure that we allow for state edits as needed. FHIR, F-H-I-R, is another kind of process for sharing POLST data between technology systems. And then NEMSIS is what EMS uses. And not all EMS, but a lot of EMS uses NEMSIS for POLST data. So if we can get these three systems, which are all in process right now, and National POLST is involved with all of them, if we can get them working on standardizing elements of POLST, we're helping the technology piece support what we're doing in the paper world as well. It's just nice to see all these things coming together. So other projects, we're working on updating our 5-year strategic plan. If you have ideas, what should National POLST tackle next? Let me know. We're figuring out our organizational structure. That'll be a September meeting. We're kind of adolescents in our organization age. We've been, kind of something to everybody, but now the question is really, what structure is going to serve us well going forward? We're creating national continuing education credits for POLST, and creating standards for POLST. So if other people create education, we're kind of creating a certification process for that. We've got some other earned income opportunities, and we're always looking for collaborative grant opportunities. Right now, I'm working on how do we take lessons learned from COVID, how we had remote advanced care planning conversations, and take that and implement it in rural communities. And I'm working with the main folks on that. So if Hawaii has ideas, we'd love to hear them. And then the last thing I was asked to go over was kind of like website stuff. So last quiz. How many sides to our website do we have? And I also, this kind of, so in our mind, we've got two. We have a patient side of our website. So you can tell you're on the page, and you'll see the patient side is gray, and you will see that the menu is bones, and we use pink. So 3 different indicators on there. And then the other side is for professionals. They're there because one professional will be gray. But pretty much everything I shared with you today can be found on the national side of the website. We also have a forum. So if you're in POLST in Hawaii, you can have access to our forum. Just talk to Jeanette and I get you set up on that. We keep that offline, again, just for people that are ending, because we want to be able to be honest about some. So Jeanette, you had said I could probably walk through the website a little bit, or do you need to move on? So again, the patient is gray, and then we've got the more pink color going on here. There's not a ton that I hand out or a ton to know about here, other than we tried to make this a very like a story of starting POLST, what they do with their POLST form, and then what happens when they actually do have a POLST. So this was very heavy on having videos. And so we try to make it interactive and easy to understand, easy to approach. We could probably do right here. Advanced care planning, again, we try to keep it simple. We used to have on here to try to streamline what we wanted to convey. The more important side, I think, is to make sure the place that I go to the most, again, governance, a web page that easily lists, I'm hoping it easily lists all of our policies. Maybe this will be a little bit faster. Map page. The map page is one, again, you can quickly see how many endorsed active states that we have. If you have questions, what happened to mature, we've got a document right here under Learn More. If you want program names, state, we provide that. And then the additional resources, a lot of the ones that I mentioned today are all right here. You can see that we have 5 different maps right now on registries, adoption of the national form, pediatric. Have the overview, state laws and grids. We have our legislative guide, signature requirements. So this is a web page that is just full of information. I get to policies again, see if that will load. Yeah, /toolkits. You can see we have 3 different Research and Quality Assurance Committee has been building toolkits, quality indicator toolkits for the last couple of years. And they're almost doing 2 more of these. But the idea is that these indicators are something that any facility would be able to pick up and use without any money or without any training, just to see if they're using POLST appropriately. So each one has 3 different options, and most of them are like chart review. But if you do that, you can get a sense of, for example, are you using POLST in an appropriate population? Or do you have people that are reaching out and providing POLST to people that are very clearly healthy? So those are, I would just bookmark that because I think it's a really great resource for quality assurance that is, again, not expensive and it's very easy to use. Jeanette, were there any other things on the website you felt like I should cover?
No, I think it's good, and I also appreciate that people can go check out these toolkits and see, depending upon, are you at a hospital, are you in a facility, are you someplace else? So, and I think people, should also notice that it's all free to download and to use. And as are most things, with doing research, there's research tools that have been used as well.
Yeah, for questions is if you're using these and you want to link to them, when you go to download, just right click and then copy the link address, and that will give you the short link. And what I mean by that is, so for short links, we've spent a lot of time for everything on our website creating short URLs. And in fact, we created a short URL for all the short URLs, or at least most of them. So you can click here, and it's a PDF that shows all. So if or policies, it comes up with a really short link. And that's what you should use for any handouts, if you're putting something on your website or whatever, because it helps make sure that you always have a page or a document that is most up to date. So right clicking, for example, on that appropriate use, when we update it, hopefully in September, if you're using that short link, automatically, whenever someone clicks on it, if you have that on your website, they'll get the most recent version of the policy. If you download the policy and then post the policy on your website, you're going to have outdated information. So using these short links is something that we're really strongly encouraging everyone to use if they're going to link to our information. So just last thing, a plug, if you want to stay up with what's going on in POLST, I know that Hawaii has an awesome newsletter, and you take what we have in our newsletter and put it in yours, which is fantastic. Otherwise, if you want to sign up for our newsletter, you can go to POLST.org and subscribe. And again, if you're involved in implementing POLST in Hawaii, you can get access to the forum. So feel free to reach out to me. Definitely reach out to Jeanette if you have any questions. And I saw a couple of questions in here, so I'm going to stop share so I can see people better and answer those questions. So the first one I saw, and hopefully you can let me know if I missed any, was from Erica. Can I repeat what I said about the reason artificial nutrition is on a POLST form? So artificial nutrition and hydration, everyone agrees that that is not an emergency order. But POLST is not just for emergencies. The idea for POLST is that it's supposed to help make sure that everyone's aware of a patient's goals of care as they go in and out of the different care facilities across the care continuum. So they're discharged from the hospital. That POLST form helps communicate to the nursing home or to the SNF or wherever what the patient's wishes are. So somebody looks at that, they create their own order set within that facility, but upon discharge, you have a standardized way of communicating to the next facility. Of course, it can be used in an emergency, and that's part of its value. But artificial nutrition and hydration, the thought from the National POLST Plenary Assembly members is that that is such a fundamental part of an advanced care planning conversation, because it can help drive care one way or another. After a certain period of time, you're looking at either a surgical approach or not, and that can deviate what you do next. And if people aren't having those conversations, that means that we have some challenges with how to honor the POLST in other ways. So we felt pretty strongly, again, as an organization, that artificial nutrition should be on the POLST form. Again, emphasizing it's not just for emergencies, but because that is such a critical conversation and we need to capture it to kind of help get the bigger picture of what the patient wants. In an ideal world, that would be done kind of through an advanced directive or another pathway, and that'd be recorded, but that's not happening either. So it's kind of twofold of, emphasizing POLST is not an emergency and that we really need to know it. And hopefully that was helpful, Erica. Let's see, the next question I saw was, why is Oregon unaffiliated? We do have a press release on our website. At the end of the day, we had a difference in where we get our funding from. And so Oregon chose not to participate. So they're not active, is unaffiliated. And there's a couple other states that are just unaffiliated for whatever reason. Again, We always invite them to participate. Those states generally are responsive, so we do an annual review once a year to make sure all of their information is accurate on our website. We still list like contact information, website, their materials, and all the states that are unaffiliated are still responsive. They're just choosing not, for whatever reason, not to participate in our governance.
Amy,
Donna.
I was asked if we could share your slides later.
Yep.
If you're okay with sharing them.
Yes, Jeanette has I sent you guys the PDF, so you can share those. Is that what you were looking for?
Great. Yeah. Yep.
Donna asked a question. Trained staff are able to have the conversation about what the form is. However, who should assist with completion with the POLST form with the patient? That's an easy answer, and it varies much from facility to healthcare team. At the end of the day, there are a lot of people that can play a role. The way that we talk about it in other presentations is, if the patient is getting an initial diagnosis, the best people to help kind of even start the process might be a chaplain and a social worker, just helping the patient wrap their head around what the diagnosis is and think about what makes a good quality of life. What do they enjoy doing? What might be goals? And just kind of help get the bigger picture in place so that somebody that can speak more specifically about the diagnosis, the prognosis, and treatment options can have a more nuanced conversations about what those treatments mean, and the patient can connect those treatments and what might happen to them with their goals. And so it can be multiple conversations, but a lot of it is, I've learned over the years, it's just how do different teams function. It's very different in a rural community than in an urban one. It's different from a nursing home to even another nursing home or hospital facility about who's involved. So at the end of the day, though, whoever ultimately signs the POLST form does have the obligation of confirming that what that order is in fact matching what the patient wants, because they're signing their name to it. And that's a medical order saying that they have confirmed, that they're testing. I'm not sure what language Hawaii uses, but in some way they are saying that this is an accurate document. So the person signing has the ultimate responsibility for confirming its accuracy.
Can I ask a question? That just went by. One of the things that I heard you say was talking about limiting access to the form. So we have the form only we have two sides of our POLST thing. It's in the professional side, and people I know go there and download it, and we don't restrict it, but that really works for us, that people across the state, the professionals can download it. We have, I would say, about 500 hits a month where people know they can go and get that form. So I know that, obviously patients are not supposed to go home and fill out the form by themselves. We know it's supposed to be a part of a conversation with professionals, but I'm interested in that we're going to soon be against national recommendations. So could you talk a little bit about that and what you've seen in other places?
Sure. And I don't know that you would necessarily be against it, because you're already putting it in a place you'd have to be a professional to be clicking on it in the first place. So yours isn't front and center like some states have it. Like some states, it's very clear, like you want the POLST form, click here. So that, and then two, I think what the Program Standards Committee is trying to do is encourage states, if they do have it online, to at least have a cover page or something when you click on it, acknowledging that this is in fact a medical order and it should be completed with a healthcare professional. So it's not restricted in that it has to be locked or something, but we want some reminder again that patients or families should not be completing this document for the reasons you just said. This is something that involves a conversation. The POLST form itself is not a low literacy document, and it was intentionally written that way because we don't want patients to be filling it out on their own. We want it to be part of a conversation. So we need people that can translate what those orders are and have a conversation to be the one that's ultimately completing it. So Erica, to your point, the reason to restrict, again, we don't want patients filling this out on their own. We want to make sure that there's credibility behind what the order is. And the more that we have patients filling it out, the more we reduce the credibility in POLST, and that creates trust issues. And that means that other providers are not going to want to follow the POLST. We already have that issue with advanced directives, where in some states like Oregon, we have an advanced directive that is asking about medical treatments. Yet I don't need to see my doctor in order to complete this. And we know from research that most people don't even understand what CPR is, because they're looking at TVs and they're seeing that it's successful 78% of the time, when the reality is for most people like 25% or lower. So when I worked at OHSU as legal counsel and we're in patient care conferences, we didn't really pay a lot of attention to that part of the advanced directive because we had no confidence that the patient understood what those medical terms were. We looked at the surrogate and we had a conversation with the surrogate. We don't want that to happen with POLST. We want to make sure that we're encouraged that process in place at all times. So for education purposes, what we encourage, and if you go to our website right now, we do have some state forms on there. Every single one of those forms has sample written across it. We want to make sure that we can give it out for education, but yet no patient can actually complete that document on their own and just get somebody else to sign it. Hopefully that answers both Jeanette and Erica's questions on that.
Yeah, I couldn't see the chat. So that's a technique that we could have on the patient side, sample on the form, because of course that is always very painful when people say my doctor gave me a POLST form to fill out, and that, Hope and I get very upset when that happens. So, okay.
Yeah, we have it as a light watermark, so it doesn't need to be like intrusive, because you want people to be able to read it. But even thinking about on the patient side, can you have a quick document form is, and we've got examples on the national website.
I'm interested what people, like the professionals on the call, what they think about that as an option, but we'll be talking about that.
Are we talking about that now or later? This is Tanya. Because I did have a question with regards to having the POLST available in packets at the time when we were doing in-person advanced healthcare planning. We take in the POLST form as well, so that we can educate the public with regards to the difference, but the connectedness with both. And we've been giving them, a blank POLST form in their packets. So we should be giving them one that says sample across. Is that what I'm understanding?
I think we do the same thing, and I don't know that the people who are filling out their own forms are getting it because of our presentations. I think what I hear, the story that I hear more is my doctor gave me this form so I could fill it out. So I don't know, Tanya, and I think we should talk about this, because I think there's a lot of value of somebody going to a well-done educational thing and then saying, hey, doc, I got this form and now I want to talk with you, because then we have to turn around and say, oh, now how is the doctor going to get the green paper and all of that stuff? So does that make sense, Amy? Anyway, I'll just say the only time I hear of people who are completing their own POLST form is that their doctor gave it to them or their health plan gave it to them. So a professional gave it to them who misunderstood that, as opposed to somebody leaving a Kokua Mau presentation and then doing it. So, for me, what I hear is the cases where somebody calls our line, they say, oh, my doctor gave me the form, I'm supposed to fill it out, what is it? As opposed to, oh, I just went to a Kokua Mau meeting, a Kokua Mau presentation, or in this case, Hospice Maui, and now I want to fill out my own form. So for me, if we've done a good job, now the person has a POLST form and they can go to their doctor. There won't be that lag time. And they heard from us, hey, you are not filling this out yourself, but you can facilitate now going to your doctor. So again, the cases I hear are not, I went on the internet and logged it and downloaded this, because where the heck would you get that ghastly green paper? It's that the doctor has done this, and then we try and follow up with the doctor to explain this is not what they're supposed to do. So anyway, thoughts on that?
Is that to me or to the group?
I guess to you, yes.
Yeah, I mean, again, I have to kind of follow the National POLST line, which is we want to have education behind the form, and it's a conversation between the provider and the patient. That said, I think we're at a point where it's still incumbent on the provider to be the one that ultimately confirms with the patient. So if the patient's getting the information and doing something on their own, but the provider still confirms that this is all accurate and the patient truly understands it, we've achieved the goal of it in the first place. Where I think we're coming from, Hawaii is advanced in a lot of different ways compared to our states. The questions I get and have gotten over the last 7 years more often are, I downloaded it from the website, how do I fill it out? And there's nothing, like they're not even using the right color, they might not even be using the right version, all that stuff. So we're just trying to encourage that not to be happening to the extent that we can.
Okay. So I would say, and I mean, other people could speak up, I rarely hear somebody say, oh, I downloaded it, I like purple better than green, and I filled it all out. I think our challenge is this: a provider gave it to me, my health plan gave it to me, which is actually easier for us. Then we can call nicely and try to give some education to the person who is trying to do that. So we can continue to talk about it. And I really like what Jackie Mock says. You would think that the doctor who's signing the form has gone through it. You would, and yet it doesn't always happen. So that's another reason I'm so glad so many people came today. And, just to clarify, in Hawaii, POLST budget from the legislature is zero. So Kokua Mau has taken this on, and for many years, that's why we are the lead agency and we do this. It's not like there's a ton of money from the state to make sure that this law is happening. We are the POLST Education Committee. So we count on you guys, and all of us count on each other to make sure that it continues to be the strong program that it is. So I wanted to also talk about, Tanya asked a question about the National POLST Form. And I'll be honest with folks, we were thinking of doing it in last year, but a few other things came up, not to make light of the pandemic, but none of us had any bandwidth to be thinking about implementing the National POLST Form. We, as you all know, also have a large budget deficit right now. So where the funding is going to come for the education and all of that, we have to look at that. But I would like to put it out there that we would shift to the new form next year, 2022. We can plan for it now. How's that going to look? What do we need to do? The good news is we do not need legislation to make that happen. Our legislation does not mandate a certain form, so we're good to go on that one, unlike other states. But Amy, you want to give us any tips as we move forward with implementing the national form and other states who should we be sure to partner with?
Yeah, and I apologize. I do need to jump off pretty much now, but I'll answer this first. I think if you have any questions, I would talk to the states that have Arizona and Maine have both completely switched, and they've started doing education on it. New Hampshire's in the process of doing that. Alaska's in the process of it. I think West Virginia's already gone ahead. So you can definitely reach out to those states and see how they did it. We held a webinar on that in December, and I think that we're going to be doing that at least once a year for the next few years to kind of figure out next steps. What do people need? Work with me on any edits that you feel like have to be made on it. That's something I have title, like the plenary assembly has agreed on what titles are appropriate depending on what changes people feel like they have to make. Bare minimum, please don't make a change unless you absolutely need to. If you want to die on that mountain, that's fine. But the idea is, can you let some things go in the interest of the bigger goal, which is creating some consistency so that patients don't have a challenge of moving between states with one document. So hopefully that's helpful. I'm always happy to chat more about that. And I do apologize that I need to jump off.
Well, Amy, thank you so much for spending time with us today. Thank you for asking questions. Thank you also for your leadership. I'm happy to continue to answer questions and have more of a conversation. Amy shared her email with us. So again, thank you so much, Amy, for spending your time with us.